Today I want to introduce our speakers, Matthew and Chris. They're going to be talking today about retail appointment scheduling and an experience that they developed. As background, Matthew is the Senior Director of Digital at Rush University Medical Center, and Chris is the Chief Operating Officer at Modea. I'll let you guys take it from here.
Great.
Thank you.
Great. Well, let me turn that on. Good morning. You guys hear me okay? Excellent. Excellent. Well, we're excited to be here. Hope you all are as well. We'll just quickly introduce ourselves in a little bit more detail as we get started. As was said, I'm Chris Riegger with Modea. We're a digital experience consultancy. We work exclusively in the healthcare space and predominantly with large healthcare systems like Rush. And all the work we do, it really revolves around the strategy and design and build and maintenance and enhancement of big consumer-facing, customer-facing digital platforms. So a lot of enterprise websites, mobile applications, and custom software as well. So I'll let Matthew introduce himself.
Yep. Everybody hear me okay as well? So I'm Matthew Sluzinski. I lead the digital and web strategy team in the marketing department at Rush. So we're a 7-person team with a heavy dose of vendor support as well. Have primary responsibility over our patient-facing website, our university website, and our Find a Doctor. So my team includes design and development, SEO, analytics, A/B testing, strategy, and UX. And prior to coming to Rush, I spent about 10 years at Mayo Clinic in digital experience and public affairs and content roles. We've been working with Modea as our kind of core design and development agency on our site since 2023, late 2023, so coming up on a couple years now.
Great. Okay, so here's how we're going to proceed today. The work that we're going to talk to you about, this is largely going to be based around a case study of this very modern and ideally as retail-centric as possible a scheduling experience that we built together. But it's really set contextually within this broader digital transformation that's happening at Rush. So first, Matthew's going to dig in and tell you a little bit about that, about the team and the work and the effort that's happening around digital transformation at the health system. And then I'm going to talk a little bit about this segment of our market that we call digital first care and just look at some of the key players in that space, some of the things they're doing that are a little bit unique that we looked at as comparators. And then we're going to present this new appointment experience and talk a little bit about the outcomes of that work to wrap up. We're going to look at some real data there, and Matthew's going to talk a little bit about what's happening next within digital transformation at Rush as well, and hope that this is a really interesting and helpful case study for you all today. So I'll let Matthew take it away here.
Chris. So I'll just start with just a little bit about Rush. So we're a 3-hospital nonprofit academic medical center serving the Chicago area. Founded 1837, 2 days before the city of Chicago itself. So we're really proud of some of our high rankings. Last year we were named for the 5th straight year to the U.S. News Best Hospitals honor roll, also really highly ranked in Vizient. So as I said, 3-hospital system, a really growing set of outpatient clinics as well in the Chicago area and in Northwest Indiana. And then a really high regarded university, Rush University, with about 45 degree granting programs. So kind of all the elements of the AMC model and about 14,000 employees and a $3 billion revenue. So I'm just going to talk a little bit about the foundation because it's going to kind of influence where we go with the project we're going to talk about today because it kind of has its origins dating back a couple years. So Rush commissioned Kaufman Hall, a consulting firm, to look at what are the top growth pathways for the organization over the coming 5 to 10 years. And digital experience was tied for first, with outpatient expansion and growth of the cancer service line. And so this really became a really first mover kind of top-down mandate circa 2022 from senior leaders that we need to be aggressively investing in digital experience a bit more. And I think Rush has made a really strong pivot and an investment in looking at digital first care as foundational to some of this growth. We operate in a really strong competitive market. I imagine many of you do as well. In our market, it's ourselves, Northwestern, University of Chicago, Advocate, North Shore, and a long list of others. And we see digital as an opportunity to reach into geos that we are not going to build a physical footprint in, but can reach patients for the first time through digital first care and still have our physical presence available for downstream visits. And also payer mix. I know everyone's struggling with strengthening payer mix and reaching into some areas with maybe a stronger possible payer mix to help balance out our care offerings. So this is kind of outside in input number one, this Kaufman Hall work 2022. We also had Avia come in 2022 and 2023. For those, many of you I'm sure are familiar, a national consulting firm in healthcare, did a really deep dive, kind of additive to the Kaufman Hall work. 50 plus stakeholder interviews, scorecarded us on about 44 digital health capabilities, benchmarked us against peers in the market, against national competitors. And the findings were not great. Fragmented, insufficient, no cohesive strategy or governance. And I remember when I joined Rush almost 3 years ago now, I started asking around kind of like what kind of projects are going on, and like the Access Center was chasing down a two-way texting system for patient scheduling, and IT was on a chatbot, and my department was somehow involved in an identity verification system for MyChart signups, making it easier to validate your identity. So kind of everybody was chasing down their own things as little small businesses across the organization, and 2023 really became a centralization year for the organization, building an enterprise-level digital transformation committee. I now sit on that for marketing that has really gotten everything on the table, full transparency to everything everybody's working on. Things can start to be balanced in terms of resourcing and prioritization and ultimately delivery. So coming out of the Avia work, these are some of the early guidepost imperatives for us. Preference. We've been saying a lot over the last couple of years, win on access, and that's going to flow into some of the projects, or the project we're talking about today. Access and convenience, meeting patients where they are. Simplifying the journey from appointment scheduling all the way through to bill pay. And then ultimately driving growth to the organization, and doing this in two ways. One, acquiring new patients through digital first care offerings that we're going to stand up, and retaining existing patients through nudging strategies, personalization, care gap closure, bringing people back in who we haven't seen in a while. So coming out of all that work, this was kind of the foundation for some portfolios that we've built. And I heard a quote from one of our senior leaders last year, like, we have the muscle, but we didn't have the skeleton. And I thought that really resonated, that like a lot of talented and well-intentioned people working kind of but in their own silos or domains. And so this is the sort of the skeleton that we built, and really spent the last 2 years on this digital consumer bucket, focusing first on things that are going to drive growth and revenue to the organization, help us unlock some of those access and capacity issues. And then this year getting now into the care transformation and operations efficiency buckets to kind of continue to round out work in the organization. So my last slide, just by way of background, like these are now our kind of guidepost or North Star themes for that consumer strategy. Convenient, simplified, personalized. And so the way I look at this is we've kind of recrafted Rush's strategy from the inside out, but we know that consumers, and this is going to go to what Chris is going to talk about, consumers are comparing us not against all the AMCs in the market only, or all the health systems in the market only, but actually against the best available consumer offerings that they're seeing. And that includes these digital-first disruptor class of organizations like Hims and Hers, like Amazon One Medical. So I think the challenge and the opportunity for Rush has been, how do we infuse ideas from those competitors, the speed, the simplicity, the convenience, the brand positioning, infuse that into our work and use that as a lever to help us leapfrog the local competition. And I think our appointment website redesign project that we're going to talk about here is really a great first proving ground for that. And all along, how do we retain the strength and the leverage of us being an academic medical center? That there's a lot of things we can do that the Hims and Hers and the Amazon One Medicals cannot. So with that kind of foundation and background, I'm going to hand it over to Chris to talk a little bit about some of that comparison and competitive market, as well as some inspiration.
All right, thanks, Matthew. So as Matthew mentioned, looking at sort of this more digital first part of the provider landscape was important to us. I want to dive into that. But first, just a quick story. I live in a college town, and my wife works for the local university. She hires a lot of students in her work. And so I went and visited her like maybe, a month or so ago, and brought her lunch because I'm a really good husband. And you all laughed, but I really am a great husband. No, it was obviously a joke. And so I brought her lunch, and one of her employees walked by, and she introduced me to her, nice young woman. And she was wearing a Seinfeld t-shirt, and I'm a huge Seinfeld fan, as all my colleagues know. and who are here. And so I said, it's nice to meet you, and I really like your shirt. And she goes, what? She looked down, she goes, oh yeah, my dad loves this show. I didn't laugh. I laugh now, but anyway, taught me a lesson that it can be important who you compare yourself to, right? Like, I was looking at her like she was my peer. She really wasn't my peer. So in any case, a little bit of levity, but we're going to talk a little bit about, getting into this work. Who we decided to compare ourselves to was pretty important. So I want to talk a little bit about just digital care first, a little bit more broadly. So when we talk about digital healthcare services, and we look at that market, all the data out there, including this data from McKinsey, says the same thing, which is that the market for sort of digital health services is really, really big. Now, in context of this data, digital health services means virtual care, virtual visits. It also means mobile enabled care, digital therapeutics, in-home, Bluetooth-enabled measurement. There's a broad market here. And like we all know this, right? Like this is in many ways the future. We can't deliver all healthcare digitally, but consumers really want and crave the ability to engage in their healthcare journey digitally when it's available to them. And the main reason is really convenience. It's a very convenience-driven thing for them. So this is a good lens for us to be thinking through as we embarked on this work together. Because again, as Matthew just laid out, some of the goals that they had organizationally, really meeting the patient where they are and really being hyper convenient for them was really important. So drilling down a little bit, now getting back into like, who are we comparing ourselves to here, right? We can compare ourselves to more traditional competitors. Matthew laid out just the very competitive environment they're in the Chicagoland area, with several other health systems that they compete with for market share. But the reality is too, in this sort of like digital health services market, there is this cohort of brands out there that are incredibly taking a really modern approach and a very digital first approach to the way that they're offering pretty traditional services, right? Like urgent care, primary care, medication and subscriptions, behavioral health, right? But they're delivering it in a really digital first and really innovative way. And so I just want to quickly step through some things that we looked at and really honed in on as inspiration when we were thinking about the new experience we wanted to create together for Rush. So the first of those is brand. When you look at the way these organizations are representing themselves from a brand perspective, they're taking, much like this example from Hims and Hers, they're taking a very modern, fresh, and very authentic approach to the way that they're communicating from a brand perspective that in many ways is a little bit unique. I think we have great brands in healthcare amongst traditional health systems across the country, but some things we can learn from here for sure. The second, Matthew spoke to access. That was a key component of Rush's strategy here, is how do we really unlock access for our patients? When we look at these digital first providers, they are leading with access. And that is because the ability to get same and next day appointments with these providers is really, really high, to the degree that some, like Carbon Health here, are really like leading with that message right on their homepage. Hey, you can have an appointment right now for these different services, for these different conditions. Just click here, right? It's a very convenient, very transactional approach. And then finally, just thinking about technology too, right? One of the benefits for these organizations being a little bit younger in terms of the tenure of their business and potentially a bit more nimble as well is they're building a system and an infrastructure where they're providing really good technology and digital tools in the hands of their customers. This example is from Lemonade Health. And they've got a really nice branded mobile app that's really well integrated and lets their customers not only join through that app for a virtual visit, helps them manage their prescriptions, track their prescriptions, manage their account, and just have a really convenient sort of digital hub for how they're engaging with the healthcare provider. Anything you want to add to any of that, Matthew?
No, well stated.
Okay. So now Matthew's going to talk a little bit about the jumping off point for Rush at that time.
Yeah, so kind of in comparison to what Chris shared, like here's where we were at as of early last year. And this dates back to like the last time the site was fully redesigned was 2020, before my time at Rush. You look on the left, that was our main appointment landing page. Very self-service, very tile and link-based. No real layered care based on acuity. It was kind of more of a hunt and peck type approach. And then on the right was a microsite that was spun up during the pandemic. We were kind of branded as Rush On Demand. It was our Get Care Today, our virtual first services. And this was never fully integrated back into the main appointment scheduling experience. So it sort of existed out adjacent to that. And these are things that we knew we needed to deal with. If we're going to be offering modern day care services digitally, we need to have a look and feel on that front door that's really reflective of those services that we offer. So as we got into the kind of scoping this project for the new appointment page, a few of the things that were coming down the line. So in addition to the Coffin Hall and the Avia work, we had some new digital first service offerings being planned. Most notably, last April, we went live with virtual specialty care online with same and next day availability in a number of specialty service lines that traditionally were very locked up on in-person access. We had also gone through in 2023 a brand positioning and refresh with Monogle, and so we had a number of brand elements, visual identity, voice and tone, key messaging that had yet to see the light of day on the website, and so we had an opportunity with this to kind of start putting that forward and unveiling that. And then, back to the chatbot. Like there was a chatbot project underway in IT with the vendor Fabric, and we were being asked to deploy that across the site. So we kind of had this kind of perfect storm of a few things coming together mid last year that really caused us to accelerate some plans to kind of rethink that appointment front door. And importantly, figure out what's the right scope of work. Like we knew we wanted to revamp this, but as everybody in the room knows, like you can go all manner of ways from like light to really heavy. It could take months, it could take years. And so as we started kind of coalescing around what the plan could be, keeping this in mind and keeping those consumer themes I shared earlier in mind as well. So as we, having Chris and Modea on the line since 2023, like they were obviously the service provider we were looking at, and I started talking to Chris about aspects of this project. And to that point about this sliding scale, I'll have Chris maybe to share a few thoughts about how we went through the evaluation here.
Yeah, and just to frame this up a bit, at the end of the day, we're trying to create a really good scheduling experience, and with Rush being on Epic, scheduling means MyChart, right? So how are we going to do this in the best way to make sure we're creating a good customer experience? Again, we're comparing ourselves to some pretty good experiences out there in the market from these digital first providers. But also, how are we going to create this in a way, too, that's going to work for Rush? So there are sort of three examples here we wanted to point to, or three options or pathways, if you will, that we considered. So going left to right, first, quite simply, is light, I'll do air quotes, integration, right, with MyChart, which is basically, let's just accept the fact that we're going to hand off to MyChart at the end of the day and just try to do it in as seamless a way as we can. So that was option one. Option two in the middle was actually doing a deeper MyChart integration, leveraging Epic's APIs that they do have available, and doing a more deep technical integration that would allow us to pull that scheduling experience forward into the design that we express, right, that we create. But we knew that work would take a lot longer, be more technically complex. We've got to have access to the right Epic resources. We've got to have Rush IT on board and willing to support that. So there's a lot of effort required there. And the other thing we didn't, we talked about a little bit was just this possibility of outsourcing, of just maybe we go find a third-party platform that could provide this capability to us. And there's some complexity there that looks a little different. There's time to find, time to procure, all that kind of stuff to make that happen. And so we initially looked down this middle path, right? And we said, okay, let's assess this. What would it take to do this? We think it's going to present certainly the best customer experience if we could allow them to schedule right within the web environment that we create for them. And so we looked at what resources we had. We talked to IT. We looked at the timeline, the cost. And so we said, okay, well, how about that light version? What does that light version look like as an alternative? So at the end of the day, Rush was really focused on speed to market. I remember at this time, Matthew and the rest of the digital transformation team were very eager to get something better in market. So we decided essentially to, with this first phase of the work, take the light path, focus more on the design, the user experience, the information architecture, because we were really creating like a new microsite almost for Rush here, and just make the handoff to MyChart feel as good and as seamless as possible. And we had a lot of buy-in and good foundation we laid with Rush IT to make that happen. So that was the path we ultimately decided to take with this round.
Mm-hmm. Yeah, and with that background, thanks, Chris. These are kind of the goals we landed on with that, ultimately with the project that we complete and that we'll start showing some examples of here. So can we get, for the first time, all of the appointment options, all of the, from low to high acuity on one page for the patient? Can they see this all in one place? Can we bring in some of the evolved brand standards that I discussed? And importantly, emphasize our digital first offerings, but not lose visibility to the fact that traditional in-person care is still 90% of our business. Like it's way up there. So we want to create visibility to the same and next day, but we don't want to shoot ourselves in the foot by kind of deprioritizing really the engine of the business, which for now is still in-person care. Mm-hmm. And then a couple other things I had in mind, like one, I felt really strongly we need to stop perpetuating the virtual care off on its own, like in a microsite. And this is just how we conduct business now. It might have been okay circa 2020, 2021 to have kind of the rush.edu/virtual care. But at this point, it's just how we conduct business. And we want to be able to present those options in line with all of the other in-person care offerings. So then, of course, how are we going to measure some of this? So a few things we were thinking about. One is, can we drive up engagement on the MyChart scheduling options? Can we drive down engagement on our appointment forms? We had like a request an appointment form, which you can expect is like this 30-field thing that went into the access center. So a human had to process that, call the patient back. Can we tamp down on that? Leave it as an option, but kind of as a last off-ramp for patients. And then phone calls. I think we'd rather get a phone call than get the form, but can we like maybe modulate the phone calls a little bit? Like we didn't have a strong KPI around that, but really it was how do we try to shift as much of this into online scheduling as we can. So I'm going to run through, Chris and I will run through kind of, here's some of the real world. You can go look at this live right now. So the first kind of theme, this layers of care, which is really as we think about how do we present all the care options in one place for patients and do it in a way that's going to be intuitive. So you can see here, like there's nothing new or unique about a quick links bar, but we really put this in as kind of a wayfinding anchor. So if we're going to put everything on one page and we're not going to bury a bunch of stuff under content-heavy child pages, can we make it easy to navigate, one tap to get to the section you want to go to, and from there, one tap to schedule. So we put this in, and also you'll notice these are kind of strategically organized by acuity of care. So starting with urgent and walk-in into some of our new virtual specialty, and then the traditional stuff around primary care and scheduling any appointment. Here's kind of a little run through of the experience now. So like that quick links, or if you just navigate the page, really presenting first and foremost our kind of Rush Connect, which I'll talk about in a little bit, our virtual urgent care and virtual specialty care offerings, also pairing our walk-in clinics alongside the virtual urgent care. So for those low acuity needs, be seen by a provider within 20 minutes via video visit, walk into one of our locations. Highlighting the virtual specialty care. So we're now live in, I think, 6 or 7 specialties with a same or next day. It doesn't always work out this way, but same or next day kind of access promise to be seen by video in some of our high demand specialties like ENT, urology, derm, heart, OB-GYN in some cases too. Primary care, and then this kind of really important schedule any appointment. And so this was sort of the backstop into the point about let's not lose visibility to our traditional in-person care. So one click into open scheduling for new patients, one click into return patient scheduling for return patients in MyChart.
Can I chime in on
go ahead.
Yeah, just to chime in on a couple of quick things. And maybe just to drive home a couple of points, like Matthew shared a few slides ago, just some of the things that on top of these goals that Rush had, right, and on top of this predominant goal of just like, let's make this scheduling experience much, much better, there were some organizational priorities that were sort of jammed in here as well, right? There are a whole bunch of services that we're trying to promote on this page.
Yeah.
I'm looking at you for, thanks for saying
Correct.
yeah.
Yeah, correct.
You keep me honest here, Matthew.
Yeah.
A whole bunch of services we're trying to promote. And by the way, we have this great chatbot from Fabric. We want to make sure we get on the page. There's just a lot that we're trying to work in here. And I think this like sort of little animated GIF here kind of gives you a pretty good view of just how we tried to structure and think about hierarchy. And with that, those quick links that Matthew highlighted on the last slide, a big part of this design experience or design exercise, right, Matthew, was like, how do we take a lot of this, which is fairly complex, there's a lot here, and how do we present it in a way that is logical and that really helps the customer think through their options and make a good decision. So
I know like some of those early conversations we had, Chris, with you and your team was, there's only so many ways, I should say, to carve this up. There's like the virtual versus in-person, new patient versus return patient, be seen now versus be seen later. And so like, where do we want to create, we were calling them like fault lines or break lines, right? And it became the be seen now or be seen later. Yeah. And within be seen now or be seen later, we have in-person and we have virtual. And you could be a new patient or an existing patient into those options. So I think like that was, I think a really important discussion was to think about framing this up. And so you've created the right kind of information architecture on the page and try to do something that's going to be the most intuitive for the patients.
Yeah.
We also designed, in addition to the main appointment page, another template that can hold kind of longer form services content. So this example is for a virtual specialty care portfolio. So this is where if the patient does need more information about what to expect, what's it going to cost, what conditions do you treat, they'd be going here. This particular service, and I'll talk about some of the results later, was really intended as a patient acquisition tool. Can we drive new to practice and new to rush patients through this same or next day access offering? The chatbot, coming back to the chatbot, Chris. So we plugged this in initially on just the main appointment page and rolled it out through the rest of the site in the weeks after. So the chatbot powered by Fabric really is three core elements. One, symptom checker and triage into care endpoints. A find care outside of the symptom checker, so you can kind of navigate through and get into MyChart scheduling endpoints through the chatbot. And then non-clinical information. So where do I park? What are the visiting hours? Helping defray some of the calls we might get about that. And I think importantly, the chatbot's serving up the same endpoints that the website is. So it took a lot of work, and I was involved in some aspects of the chatbot, but like, where do we map all the endpoints, and how do we validate that everything's going to the right spot? And actually, we had a lot of work to do with Fabric, who had like not really dealt with before the idea that we would want to send a particular thing into a virtual specialty care versus an in-person specialty care versus something else. It was like their model wasn't flexible enough, and so we were able to kind of break down some of those barriers and I think really build something that gets people to the some of the virtual first services, but still offers the in-person care if they want it.
From a design perspective, you can kind of see here highlighted, but on the main appointment landing page now at Rush, there's at the sort of on the left-hand side highlighted of this slide, you can see there's some pretty prominent messaging for Fabric, for the chatbot on that landing page. And then there's a persistent at the bottom right sort of footer of the screen. There's a persistent icon that stays with you, I think across the whole scheduling experience, right? If I
across the whole
correctly.
website.
Across the whole website, yeah. So using a paradigm that's pretty well known for all of us, the sort of like little get help icon that stays with us throughout the experience. And so as we get into data later, sort of keep that in mind in terms of where that lives across the rush.edu environment.
And a couple other things we're able to do, kind of using that same look and feel as I shared on the last page. So care bundles, like looking at how do we package up specifically our virtual specialty care and in some cases virtual urgent care conditions treated into these care bundles for personas of what you might call like strategic interest. So we started with men's and women's health first. So these are both live out there today. Also provide really good landing spots for paid campaigns that we've been doing. And I think as Chris and I have talked about, like these provide, I think, among the clearest comparison to some of the digital disruptors. Like we felt really strongly that you should be able to click on a condition and see what's available today or tomorrow to be treated. No dead ends and no sending people back kind of upstream in the journey. Like I'm not going to click on anxiety and then get asked like what department do I want to see, or am I a newer return patient. Like we want to like use those as some guiding principles. And Chris is going to show a couple examples of that next year.
Yeah, great. So talked a little bit about how we were going to work with MyChart for scheduling a little bit earlier in the presentation. So as we stated there, the goal here was let's use MyChart out of the box. Let's work with Rush IT to try to make that as nice an experience as we possibly can. As Matthew just said, a big part of that was we did not want to have a single scheduling link that we just like throw into every place across this experience so that you're just constantly dumped into a decision tree in MyChart every time you click schedule. So we went through the work. Our UX team did some great work just really kind of cataloging and mapping out the experience and the information architecture, because there are lots of places contextually throughout this kind of microsite experience, at this new experience at Rush, where you can elect to sort of step away and schedule, right? Sometimes it's usually it's condition oriented, but sometimes it's specialty or service line oriented or maybe some other context as well. And so we went through that work and figured out exactly what we needed, and then we got in front of Rush IT and worked with them to create a series of deep links that we could place in the right spots throughout the experience. So literally, like you can see here, I think this example, sorry, Matthew. I think this example is on the woman's health page, and it's a heart health example where if I say I want a heart health consultation, this is literally the screen I see in MyChart. Boom, I'm taken right into schedule for that specific type of appointment. As opposed to, I might say I just want a dermatology appointment, right? And I get taken to a different page with a different context and a different scheduling flow. So it has worked really well, we think, and at least contextually for the customer, there's that pivot point of like, now I'm ready to make my appointment. I'm stepping away into this new place where I'm going to schedule that appointment, which obviously for us on the inside, we know happens to be in MyChart. Also, the MyChart logo is on the screen, so that also tells you that as well. So yeah, it works really well, and again, just really met that goal that Matthew laid out of we want to make sure every click is valuable. We're not pushing anyone further up the funnel in that scheduling experience at any point. All right, Matthew.
So yeah, I'll say a little bit about kind of results we've seen here and what's next. So these, I'll walk through these data points. So we went live with this experience November 1, 2024. So we've got about 6 full months of data at this point. And all these data points are, with the exception of the appointments scheduled one, are all just from that appointment landing page year over year. What are we seeing? So this is not site-wide. It's just really how is that new appointment page experience performing. So significant uptick in reach and page views onto the site. 23% increase in click-throughs into the MyChart scheduling flows, 37% increase in phone calls. So this was not a expected or really necessarily warranted thing we were looking for. But as I was looking at the data for this, the MyChart scheduling click-throughs are about 20x the phone calls. So 23% of a much higher number compared to the 37% of a much lower number. But regardless, we're seeing higher engagement with our scheduling options from patients.
You also did away with the form fills too, right?
Yeah, and the form fills. So the form fills are still available, but they're literally the last thing you're going to see on that appointment page. And we've been able to tamp down the engagement on that button and click through by 86% since we launched this site in November. And then in the virtual specialty care, so this went live, as I said, last spring, and we were using like the old version of the stuff I showed, and like the 6 months against the prior 6 months, 2.5x in appointments scheduled. So we are driving significant new volumes into this important service for the organization. 25% of these patients have never been seen at Rush before. 95% of them have never been seen in that specialty before, and they're about 80% commercial pay. So we've been able to really, I think, meet some of those objectives of reaching new geographies and strengthening payer mix through this. So a lot more work to do as we scale this up in the coming years, but I think some really strong early results. Then what about the chatbot? Lifetime to date, 46,000 sessions, 5,700 people self-identified as not been seeing at Rush before. So at some point in the kind of the symptom triage or checker flow, it asks you, like, are you an existing patient? And 5,700 people were not. So again, like that reaching new populations. And then a significant amount, 18,000 plus, that led a patient to a patient care endpoint. I guess the leftovers would be non-patient care endpoints or people that just never got through to an endpoint. But I think some really strong data to show that the work that we put into this tool is starting to pay off a little bit in terms of expanding reach and like ultimately leading people into care destinations. We also started literally day 2 after we went live with some experimentation as we thought about how do we continue to optimize this page. So we use VWO for our A/B testing and had noticed like kind of in the early week or two, the most common trafficked page after the appointment page was the appointment page. And we thought like, why is that happening? And it was because we had like in our global menu a schedule appointment button on every page, including when you're ready on the appointment page. So we suspected a lot of people were looping. So we got rid of that, or we tested getting rid of that, 31% reduction in people who were refreshing the page after we hit that button. And then we also did a number of tests on that quick link strip. We looked at the order of the links, we looked at the wording in the links, we added and deleted things from the links. And we had some kind of early anecdotal feedback from leaders that, to that point about like, you're overcooking it on the digital stuff, and can we like make sure we're not losing traffic and visibility into the in-person care? So we did some tests around the labeling. We had called it all appointment options. We relabeled it to schedule any appointment and saw a 25% increase in click-throughs on that particular quick link when we did that. We've also trialed different orders of the links, as I said, and like some of the stuff was inconclusive, so we haven't implemented it. We're going to continue to work on this throughout the year as we try to optimize for our metrics. So where are we going next? Like here are a few things on the roadmap for 2025. So the virtual specialty care work I mentioned. We're first in market in Chicago with these. We went live this Monday, 2 days ago, with medical weight loss and with sports cardiology. We're going to do a package of second opinions later this year as well. Looking at how do we supercharge the experience that I showed you. Like, do we want to go more heavyweight? Do we want to be thinking more aggressively about how we create more of a shopping-like experience? Chatbot, getting possible live chat into the chatbot in addition to just the bot chatting. Looking at our service line web experience, so this kind of goes back to the 2020 last redesign. And I know there's been a lot of like points made at this conference this week about like, is your site kind of a content engine or is it a transactional engine? And like what we showed today is a transaction engine, but there's still strengths and selling points and differentiators that we need to be selling about our service lines. And so taking a fresh look at all of that within our core priority service lines this year. And then excitingly, a subscription offering coming this June will be a first in-market subscription offering to Rush for anybody who wants to sign up. Low monthly rate, live access to a human navigator in our access center, and virtual and e-visit care on demand, 24/7, 365, all 50 states. So we're excited to be preparing to offer that in the coming months. And all this wouldn't be possible without some marketing and communications around it. So we've worked up kind of Rush Connect as our portfolio of virtual or digital first care. And so within that's a lot of what I talked about today. It's also our redeveloped mobile app. We went live with that, version 1 of that earlier this month. The subscription model under there. We're also looking at models for virtual first primary care this year. Then I'll leave you with like some of these ads. We've been running some like out of home and digital ads, and in some cases like taking some shots at some of the digital disruptors. So it's been kind of fun, like kind of moving, and this was kind of spawned out of some of the new brand positioning and brand refresh work. So I'll leave it there. I'll see if Chris has any closing thoughts, or we'd be happy to answer any questions you have.
Yeah, no, happy to move on to questions. We have plenty of time, and we wanted to make sure we left ample time for conversation if there is any. There's a question in the back here.
Hey guys, two questions for you. One is, you have data around the percentage of people that go to the chatbot versus the click experience, and the big which. And the second one is, do patients view the virtual or the retail type appointments as like a primary ask or a secondary? Those that were going for that first, they couldn't get what they wanted, so then they did go out.
Yeah, good question. Can you what's the first part of that?
The mix between chat versus click.
Yeah, those who like sort of hit the experience and go chat versus go. Is that essentially what you mean? Like when they get into that scheduling experience?
Yeah, what do people want? Do they want chat or do they want click?
Yeah. So I don't know,
I don't know if I have any like crisp data on that. I know the chatbot sessions, like 46,000 in 6 months. like we see that much traffic just on the appointment page in a month. So like there's clearly more people doing kind of web first, and like a portion of those are engaging with chatbot. To the point about the virtual specialty care, again, like we haven't done any qualitative research about like what are people doing first or second, but I'll tell you what we have seen is there was a lot of, I don't know if concern, but like some wariness that these were going to be transactional visits, that like people were going to come in and we're never going to see them again. And actually we've seen that for every 2 people coming in that virtual specialty care, it's generating 1 downstream in-person visit. So kind of like a 0.5 for every visit. That could be imaging, it's procedures, in-person clinic visits. So I think that's been a really strong validation of the program, that whether patients are defaulting it to them first or second, they're still staying in the family afterwards, which I think is a lot different than maybe the sore throats and the fevers and the virtual urgent care model.
Is it on your roadmap to actually go that deep approach with Epic and MyChart? Or
Do you want to speak to that here?
because we've done an implementation with WellSpan where you're actually using a third-party identifier. You create a JWT token on the MyChart side, cross-pollinate, so that you only log in once, and all your deep linking works perfectly fine, and everything. It is complicated. It's extremely complicated. But I was wondering if you were planning on going down that path.
Yeah, I think we haven't made a decision on that yet. I think there's like our new kind of planning year in July, looking at like what do we want to do and how big do we want to go. Because I think there's still plenty of room to, like you looked at some of this, like the MyChart experience is not the greatest looking experience, right? Like there is some kind of it's a little jarring to go from what we designed over to that, but like those are the trade-offs, right? On the budget we had, on the timeline had. We did all this in about 2 months,
Yep.
2.5 months. So there's more, it was really not intended as a final state. It's really a bridge to something, and we're still figuring out like how much more can we make this retail-like? Can the patient put in what their symptom, and we layer out all the options for them, kind of because we've aggregated all of that in some way. So I think we're probably going to move in that direction. I think there's still a lot of specifics to be unraveled.
Yeah, I think to add to that a little bit, sorry, I won't forget the 2 hands I saw, but just to add to that a little bit too. So we've had the experience of helping many clients integrate with MyChart in multiple ways, including fully custom. And I think it really just comes down from a complexity standpoint, from my point of view, just like how deep is the integration in terms of just like the features and the sort of use cases you bring forward into the user experience, and then how much complexity then that leaves in terms of just maintenance, APIs, staying in pace with quarterly updates, and ultimately like how much Rush IT wants to absorb of that work, obviously. Yeah. So I think that is probably a part of the equation too, for a big part of it for Rush.
So, question on your guys' current approach. Where, at what point does the user log in to be able to see the scheduling available times? Or are you not having them log in any way, shape, or form and presenting those? Because if you are, then what is it doing to the bottom line that you have to pay Epic? Because now you're presenting a bunch of data where you're going to have to pay per hit.
Yeah, so everything we showed today, like all those condition-based clicks are just into MyChart open scheduling. So at some point that patient's prompted to like sort of self-identify that they've been here before and like log in to complete that visit.
The whole MyChart account and go through all that.
Ultimately at the end of that process. But it was really important to us to like surface those days and times like in the one click. Like don't send me from the condition scheduling over to log in and then like cycle me through a few other screens before I can see the days and times.
Thanks. Sorry, go ahead right here.
So to follow up with that, do you not use decision trees for your open scheduling?
We do use decision trees, but what we're showing here, like we've just jumped way to the end of them.
Yeah, in the right context.
Right?
Yeah.
So there's buttons on the same appointment page. Like if you go in kind of to the front door of our virtual specialty care, it'll ask you what specialty do you want to be seen in. It'll ask you if you've been a Rush patient before. It'll ask you what condition you want to be treated for. It'll ask you if you want to pay $99 instead of us billing your insurance. And then it'll get you to the days and times. But like to Chris's point about the deep links and not sending people back up the funnel, we've just got the deep links to skip you all the way down. If we know sort of in context that you clicked a link that said hair loss, we can send you right down into the days and times.
Yeah. Sorry, there's a question here, and then.
Yeah, around chatbots, so they were really popular, and then they're getting better, and people are excited about them again. Were your goals around the chatbot more just a different channel and another way for patients to be engaged and find their care options, or were you trying to reduce call volumes? A lot of times they're implemented because they want to reduce call volumes. Was that part of your thinking?
Yeah, I think it was more like, can we bring in a modern day guided experience for patients? And if it reduces call volumes, I guess all the better. But it's, I don't know, I was talking to Chris yesterday about like just people's familiarity and interest in engaging with these tool sets seems to continue to increase. And actually, Chris, you had some data that like some Harvard study, like the adoption of AI tools is already outpaced the adoption of the PC in the internet 3 years in
the same time, in the same
time frame, right?
Yeah.
So like you're continuing to see adoption of these, and I think it was for us just like, can we bring in something that is a best practice and use it, as you see, to like drive people first and foremost into our care venues.
Sorry, right here.
Can you tell us about your internal process of opening up the schedule and how you got physicians and clinics on board, or was that an issue?
Yeah, so the IT team has been doing work for a couple years now to kind of do scheduling modernization and standardization and try to get more and more appointments available for online scheduling in the first place. And I think like the culture at Rush has shifted really positively in that direction. Like there's a lot of outliers still not on open scheduling or online scheduling at all. But that's really been a prerequisite to jump on this. And we've had departments that have like raised their hand and say, put me on, like we'll turn on all my scheduling because I want to jump on the train here. So I think like it's still a challenge, and I think we're still working through, or IT is still working through kind of department by department, specialty by specialty, because we see the same kind of pushback that I'm sure all of you seen, like kind of the quote wrong patients coming into my appointment slots, or things like you're booking the virtual visits not in a block and they're like all over the day and I'd rather have them in a block. So kind of just working through the personal preferences, but I think like the culture has been pretty good, and there's a lot of interest in even top-down directives that like by default we need to have this stuff online. Only if there's exceptions is it closed off.
So out of the, you said you a couple things. One, the word performance recommend online. Can you give us an indication of kind of where you're at, if it's possible, like it's percentage of departments or something along those lines. And then number two, if you're skipping, some of the decision tree information, are you then coming back to it? Has IT been able to rework that a little bit, or is it just we agree that this is okay to skip?
I've not heard any pushback on and I don't know if we're really skipping. Like we're sort of assuming some things based on where we know you came from, and ultimately like the patient has to write in even at the end, like what do you want to be seen for, like the box, like what's your most important thing you want to be seen for today. So I don't think that's really been an issue. As far as like, I don't have like the exact data from Access, but like some of our areas still mostly offline, or like GI is mostly offline. I think some of orthopedics is mostly offline, but like primary care is all online. And most of these other specialty areas, at least for new patient visits, are online. So unfortunately don't have a straight percentage for you.
Really geared around primary care and a lot of new patients.
Yeah, primary care, but also like a lot of the specialty care is too. Like if you go into just like our true MyChart open scheduling front door, we've got 15 or 20 specialties there that have some availability for online.
Yeah.
Thanks for the show. It's really great information. I'm curious about the governance between your team and other parts of the organization, because one of the things I keep hearing is patients don't know the difference between Rush.edu and I'm going over to MyChart, right?
Yeah.
It's just another click. How does that governance work at Rush? Between what you guys own or manage, or how much you're in kind of the MyChart experience?
Yeah, so I'd maybe start with like just the overall governance that was put in place 2 years ago now, like an executive level enterprise-wide digital transformation group. So sitting on that chief medical officer, chief operating officer, president of the medical group, all the C-level folks, and then representatives from all the departments. And so that's really where you have this central portfolio of projects, and then like a small digital transformation office hub. So 4 or 5 people that have been kind of running the projects and the portfolio itself. So then my team in marketing, like I provide some strategy input to some of this, but we're also like a hands-on service provider into it. So it's bringing all the right people to the table, I think, is where I would start with that question, that the CIO is on it. So like you've got every functional area bringing a rep, and I think like a lot of the turfing has been significantly reduced because of that, because you have the shared visibility and understanding to what projects are we working on, what sequence are we working on them, and we've got buy-in across the organization toward what's important. So I would agree with you, like that handoff to MyChart like leaves a lot to be desired, but it's, I don't know, I don't think we hear much about the confusion there. I think it's certainly something we plan to improve on, and like to that earlier question about like where do we go from here, we would have loved to kind of bring a lot of that data forward, as Chris said. Like could we pull that stuff right into the Rush StudyDo experience so you don't have to ever see the MyChart design. But we're not there yet. I think we're going to get there in the next year or two though.
I have another question in regards to the chatbots. How rigorous was your evaluation to ensure that the data that they're collecting is in a HIPAA compliant environment?
They're under a BAA. I'm not. I wasn't in the procurement of the chatbots, so I don't know if I can speak specifically to that.
Once they sign a BAA, doesn't mean that their data is encrypted at rest or things like that. So they might say like, yeah, I'll sign a BAA, but is the data actually HIPAA compliant?
Good question, right? Yeah, I mean, I think it's something I would trust our cyber team and IT have looked at, and at least the way we're using the chatbot right now, there's like limited, if any, PHI coming into it because we're pushing out to MyChart. So like the user is like identifying maybe a condition they have and like had they been seen before and seen at Rush before and like maybe the zip code they're in. So we're collecting some PII, but once we get into actual scheduling, that's all not being handled through the chatbot at this point.
Yeah, I'm just saying like, I don't know if they're collecting an IP address. So then now you have an IP address with a condition.
Yep.
That's violating HIPAA compliance if it's not encrypted properly at all.
Yeah.
Right.
Yes,
that's why we undertake things like the BAA, and then if we want to like talk about the validity of the BAA, I guess that's a different, like we could keep going, right?
If they say they're HIPAA compliant and they're not, then it's not.
The tool is Fabric. You know, you can check it out. Any other questions? Awesome. Oh, go. Oh yeah, no, good. We have time.
We're
Yeah.
adding in more is like part of our primary care. Are you guys offering virtual care with your primary care providers, or is it a third party provider?
Yeah, our current on-demand, like so our Be Seen in 20 minutes by an APP was stood up through the emergency department in 2020. So it continues to sit administratively within the emergency department, where there are dedicated APPs who staff that service. So it's not leftover capacity from primary care, and it's not a third party. It's all in-house.
Great question.
Do you fill up the virtual?
Capacity.
Yeah, I don't know if I have the capacity figures offhand, but like we've seen steadiness and growth of that portfolio over time. And there's like a lot of questions like where does that go from here, given the like everybody rushed into that market if they weren't already there in the pandemic, and then how do we continue to offer that as in some cases like it's not a differentiator anymore, it's just something people expect. So maybe there's things we could keep adding to that to continue to grow it, but just continuing to kind of treat that as a foundational item and not something that we're out like really trying to promote as a growth opportunity for the organization.
All right. Thank you so much. Hope this was helpful. Appreciate it.